begin our fourth webinar about CKDu.
Great. Yeah, so thank you, Vicente, and welcome everyone. We're really happy to be having this webinar. It's took a little bit of work to schedule it with everything that was going on with COVID and other issues, but here we are, glad to be here. So this webinar, the focus is on intervention studies occurring in Central America, which is important and timely topic. Each group, we have two groups that are going to be speaking. The first group will be from University of Colorado. We'll talk about their work in Guatemala. And the second group will be the Adelante Initiative, who will be talking about their work in Central America, Nicaragua, perhaps El Salvador as well. Each group will have about 20 minutes for the presentation and then about 7 minutes for questions. We're going to submit all questions will be taken by chat. So if whenever you have a question, feel free to post it. We'll take questions in the order in which they are received. And and then just one other thing is that in past webinars, people have just put into the chat where they are calling in from, and we have found that to be interesting, both to have that information and also for people to look at. So if you feel inspired, go ahead and just let us know where you're calling in from. I think that covers everything, and Vicente, I'll turn it back to you.
Yes, just one important thing, put your mic in off, it's really important. And after every conference, we are open the chat for the question and answers. And let me introduce our first speaker from the University of Colorado. Es un verdadero gusto presentar al doctor Lee Newman, es un profesor ampliamente reconocido en la Universidad de Colorado. Les resumo que ha dedicado su vida a mejorar la salud de los trabajadores, particularmente en áreas de alto riesgo, de alto impacto para la salud. El profesor Newman también ha aportado iniciativas de ley que han servido en otros países para poder mejorar la salud de los trabajadores. There is Lee Newman's CV is really huge. He is an author. He's a leadership in many fields of the health workers, and it's important to introduce him as one of the leaders in our community here in Guatemala, who is study many in the topic of CKDu. So. This is Lee Newman, and then Dan is going to introduce our next two speakers.
Yes, so I'll just note that Jamie Butler Dawson was also scheduled to speak, but she has a family medical situation, and she won't be able to join, so Lee will be the only speaker from the University of Colorado. The second group speaking will be the Adelante Initiative, and our first speaker is David Wegman, who is from my area of the country, Boston area. Dave is a physician epidemiologist who's been involved in research and teaching related to occupational health. Among other things, he built the Department of Work Environment and the School of Health and Environment at UMass Lowell, which has a great reputation. Since 2014, he's been working with La Isla Network, working on studies of etiology and intervention effectiveness for CKDu, and been active in both, carrying out studies in both El Salvador, founder and current executive director of La Isla Network. And he has a background both in film and communications and also in epidemiology as an MSc from the London School of Hygiene and Tropical Medicine. The La Isla Network's objective is to work on research and policy that will increase our understanding and prevention of occupational heat stress, CKDu. current focus is on the Adelante initiative and PrEP programs to protect workers from occupational heat illness. It's been recognized, both Jason individually and La Isla Network as an entity have been recognized for their work in terms of sustainability for protecting workers in sugarcane. And at the bottom, you can see of the slide, you can see the sources of support that they receive.
All right, so it's my pleasure to introduce Professor Lee Newman with the first talk about the interventional studies here in Guatemala. Es un gusto presentarles al profesor Lee Newman con los estudios de intervención en nefropatía mesoamericana acá en Guatemala. Lee, welcome.
Thank you, gracias. Can everybody see my screen okay?
Perfecto.
Very good. So what I'd like to do with the next 20 minutes and then hopefully some time for questions is to talk about some of the work that we've been doing over the last 5 years and some of our lessons learned. Let me start by telling you that we're going to share a PDF of all of these slides so that you can go back to them later. Lo siento, the slides are not, they're all in English, but we're happy to assist by sharing the slides. We are the Center for Health, Work, and Environment. We're one of 6 centers of excellence funded by the Centers for Disease Control, National Institute for Occupational Safety and Health. And I'd like to explain a little bit about our approach centered on that, but let me start with acknowledgements. For the work I'll be showing you today, it's a collaboration of the workers at the University of Colorado and at other universities, as well as with the Pantaleon Group, which is a agribusiness in Latin America, which has been very helpful in giving us the access and the data and the collaboration to conduct some of the studies I'm going to show you. We have, as a matter of disclosure, every presentation I give, I explain that we have a collaboration between our university and Pantaleon. There's a memorandum of understanding for research and consultation. I personally receive no remuneration for that. We're also funded for this work by our chancellor, the US CDC's Mountain and Plains Education and Research Center, and an NIH grant. And the opinions are my own. They do not represent anyone else's opinions. As an overview, let me touch on the approach that we take to intervention studies, tell you a little bit about some of the intervention studies we've done thus far, and suggest some of the path forward. So ours has been what I would call an international total worker health collaboration. Total worker health is a concept that we address the health, the safety, and the well-being of workers in a more holistic way. And that has been our goal for understanding the potential causes and management of chronic kidney disease of unknown cause, CKDu. I want to note that in our relationship with Leon, we have maintained and have the independence to analyze all the data, to have access to all the data, and to publish the findings as we interpret them. The total worker health approach is one that takes into consideration both the physical health, such as the amount of kidney injury that a worker may have, but also mental health, social health, and occupational and environmental health factors. So it's a more holistic approach to the problem solving. And kidney disease has been just one of the issues around total worker health that we've been addressing with the agribusiness. So for example, we've been looking at nutritional assessments, hearing conservation, noise exposures in the mills is an extremely important issue, and even around COVID prevention. So it's a more holistic approach, of which kidney disease is a very important facet. Our approach is a community participatory approach, which has included observational research, piloting practical interventions, which I'll show you today, then implementing intervention programs with the idea that those can be scaled to reach larger numbers of workers, and I'll show you an example of that. You may be familiar with this paper that Inika and Rick Johnson and I published this last year in the New England Journal, which I put up here just as a way of reminding people that if we're thinking about interventions, we have to be considering that there are potential unknowns around nephrotoxins. Certainly, the importance of heat exposure is center. Potential infectious agents. And if we're trying to reduce kidney inflammation and tubular injury, we're really having to have approaches that in some way try to address probably more than one of these factors at this time, even as we're discovering how much some of these contribute more than others in different parts of the world. The strategy is understood very well by those of us in the field of occupational safety and health. For any of those potential causes, we think about how can we eliminate them, substitute safer practices, have engineering controls, administrative policies, protective equipment, and education as the main ways in which we try to design interventions. And we design interventions with an eye toward using a framework for intervention science. So, for example, a colleague of mine at the University of Colorado back in the 1990s published a very influential paper on evaluating public health impacts of things we do to promote better health and called it the RE-AIM framework. That's Russ Glasgow. This is from his original paper. And this RE-AIM framework, before we start any intervention, we ask ourselves, will it have the reach that we want to the audience that needs it, to the workers in this case, and probably to the communities? Will it have efficacy? And if it has efficacy, is it going to be effective when it's brought to a much larger audience? Is it practical for it to be adopted by communities, by employers, by individual workers? By family members? Are there challenges to implementation, and how can we have implementation not become a barrier to the success of the intervention? And then can it be maintained? Can it be sustained over time? Is it too expensive? Is it too impractical? Or is it something that is really developed by and embraced by a community such that it can be maintained over time, so that it's not like many public health interventions, something that works for 3 years and then the funding goes away and there goes the intervention. Let me turn then to our intervention studies with that introduction. And I can only share with you some of them. These happen to be a few pictures from the fields in Guatemala. And it shows some of the field nurses filling some of the jugs for the workers as part of a study we were doing on electrolytes, and it shows a worker in the field. I want to give you right now some take-home points. I'll come back to these, but I want to leave you with them right now, and then we'll come back. 4 key points I want to make is that in our experience with interventions, water, electrolytes, rest, and shade are centrally important. They do not by themselves solve the entire problem of CKDu. So it's necessary to apply what's referred to as the precautionary principle. If you have a suspicion that something may be harmful, take steps to mitigate, to reduce those exposures as well. In this case, there are a number of nephrotoxins of concern. Third point, for seasonal workers, our findings would show that you should be screening for kidney injury early in the season and more than once during the season to identify the subset of workers who are going to more rapidly worsen during the season, and then take steps to reduce their exposures, to educate, to protect them more, to monitor them more carefully, and give them early referral for medical care. And then fourthly, I want to emphasize the importance of looking at acute changes across even the work shift, because cross-shift changes in kidney function and in hydration, indicators of acute kidney injury, are going to help in the long run to reduce the risk for kidney disease by the end of the season or the next season. So these are just some take-home points right away. Let me talk about some of the research that we've been doing. And our approach has been generally to start with the research, conduct pilot implementation studies. These would be called pragmatic comparative effectiveness trials, would be the technical term for them. Then to do program implementation and evaluate what's worked and what hasn't worked, and then improve. And I'll tell you a little bit about some of the trials that we've done: field trials on hydration, some intervention trials, a new hydration program, and then efforts more recently to evaluate and modify the programs. But I want to mention some of the things that are continuously happening in all of our programs. One is maintaining our focus on worker health and safety. Secondly, working through collaborations to find practical solutions, because none of us has all of these answers. So this is a community that has to engage. We also emphasize capacity building. When we're working with our partners in countries, we want to make sure that they have the skills to conduct the work, and then we fall into a more advisory support capacity. And then we're always looking at how do we disseminate the information. Today is an example of that dissemination. So one of the questions that we asked early on is, does kidney injury occur when sugarcane workers are well hydrated? And we said we would look at both the acute injury, and we've also done studies on chronic injury. So the objectives were to test a wellness incentive and enhanced education to try to reduce the risk of heat stress and dehydration. Evaluate acute kidney injury across the work shift, investigate the impact of heat, dehydration, and other risk factors on kidney injury, and we did that at 3 time points over a 6-month harvest period. Shown here are some of the education materials, helping workers recognize when their urine was too concentrated, giving them the educational information, and then providing actually an incentive for them to maintain their hydration. And at the beginning of the shift and the end of the shift, as people were weighed and their specific gravity checked in their urine, if they maintained reasonably good body weight, then they received tokens. And at the end of the work shift, the workers were very enthusiastic to participate in raffles, which were reinforcing the principles, the educational principles, and helping people realize that they actually did report feeling better when they maintained better hydration. So this was one of our first practical field studies. And what we found was that water, rest, and shade protocols are necessary and beneficial, but we found that they were not completely protective. And so we knew that we were going to have to look at other strategies. And I'm giving you some of the references here in the bottom corner. At the end, you'll have a list of all of our publications. We observed, let me just check my time. Oh, perfect. We observed indicators of heat stress and reduced kidney blood flow, including high uric acid, acidic urine, and inflammation, even though these people were very well hydrated with this, especially with this incentive. In fact, some people had overhydrated, and we've had to help them scale back how aggressively they hydrate. But the factors that increased the risk for kidney injury were lower kidney function before the season started, and if they had evidence of dehydration at the end of the shift. In addition, people who reported using a lot of non-steroidal anti-inflammatories, which we know can be nephrotoxic. Diclofenac is very popular in Guatemala, for example, diclofenaco. Those were the statistically significant risk factors for acute kidney injury. Protective were the use of electrolyte solutions that were offered by the employer, and if their hydration status was good at the end of the shift. So here's an example where we had groups of workers who had this intervention. We were able to compare them to other groups of workers who were not part of the intervention. We also asked the question, since we had this indication that electrolytes seemed to be important, we asked what were the optimal amounts of electrolytes for, in this case, sugarcane workers to be using. And remember, sugarcane work is extremely hard work. These workers are working, they're up early, they're working a full day in hot, often humid conditions. The average sugarcane cutter might cut an average of 6 tons of sugarcane in a day, cut, lift, trim, stack. So under those conditions, traditional, for our country, OSHA recommendations that, you get enough electrolyte through your food, we didn't think was going to be adequate. So we designed a 3-week trial among 50 cane cutters. We did pre-testing with them on the flavoring, on the acceptability, on what they felt that they would find acceptable in terms of the saltiness versus the sweetness of it. And within this group, we did 3-week trials among 50 cane workers, starting with having 2.5 liters of electrolyte solution in addition to as much water as they wanted to drink, 5 liters in week 2, and then up to 10 liters, where essentially all of the water that they had during that week was included electrolytes. What we found were the electrolyte levels were able to remain pretty stable throughout the study. Consumption of electrolytes reduced muscle damage as measured by creatine kinase, and there is a certain amount of rhabdomyolysis subclinical that is occurring almost every day in almost every worker. Workers also reported at the end of the work shift they felt better and had more energy with the increased electrolytes. And so we came away with a recommendation for offering a range of between 5 to 10 liters of electrolyte solution as being ideal for cane cutters. And the solution itself, which I haven't memorized, but it's not the traditional WHO formula for rehydration. It's a little bit modified from that. The next question we asked was whether any of these findings could be scaled up into a new, broader workplace program that could reach tens of thousands of workers in a season. And for this work, we conducted in Guatemala, Nicaragua, and Mexico. And the program was one in which the company was making available to all workers 5 to 10 liters of electrolyte fluid, plus whatever free water they wanted to consume. They had weekly evaluations by trained field nurses, and our team made a direct evaluation observation of hydration, blood and urine electrolyte levels, muscle breakdown, kidney function. In Nicaragua and Mexico, we helped evaluate some existing hydration programs. The main finding from the Guatemala study was that access to electrolytes improved once the company was able to scale up and put in place a standard protocol across the entire country. The results of this confirmed what we had done in our pilot with the smaller group of workers, and it established the feasibility and our ability to maintain an intervention like this for a company that was willing to invest in this kind of activity, and where we had worked with the employees, with the workers, on the acceptability and the education of the electrolyte solution and the hydration protocol. One of the other studies that I'd like to tell you about is asking the question of whether kidney damage could potentially be reversed through the interventions. And many of us have come to, through the literature, come to see the worst of the worst. We have seen terrible sadness, pain, and suffering from CKDu. But the question is, if you can catch people early in the stages of kidney injury, could it be stopped? Could it be reversed before they go on to develop end-stage kidney disease? So we conducted a retrospective part of the study, 5 years of kidney function data obtained.
Sorry to jump in, but just you're 18 minutes in.
I'm 16 and a half minutes in, but that's okay. I'll keep going.
Okay.
The perspective part of this, we looked at trajectories of creatinine decline pre and post our intervention. And I'll give you some preliminary conclusions. which is that the rate of decline over multiple years precedes the point where people become clinically obvious as having kidney disease. And if you identify them early, that we do see that there can be a stabilization and in some cases even an improvement. So early detection is extremely important. And not everybody declines. Some workers actually stabilize and improve their kidney function. So more on that in the future. I want to point you to a paper that we published which highlights the take-home messages that I gave you on my earlier slide about managing heat-associated risks, precautionary principle, conducting screenings early in the season and frequently, and educating workers and communities on the importance of these interventions. And there's a paper for those of you who would prefer to read our findings in Espanol. A shout out to our colleagues who made it possible for us to publish this paper in Spanish, which summarizes all of the findings I've shared with you today. And here's from that paper. The path forward to finish. I think that there's an opportunity. This is from a very interesting paper by Emily Wright on researchers' perceived challenges in studying CKDu. And one of the things that we've actually observed is that in the presence of a private company that was able to allow us the research access and to be able to work with the workers and with the funding that we were able to obtain from the NIH and others, we could overcome some of the logistic challenges that we face. And we hope to be able to see that scale to other enterprises. I want to end by talking about what I think we as a community have as our opportunities. First of all, I think it's important that you realize that we don't have all the answers. I don't pretend to have all the answers. I know that the LEANS people feel the same way. We have to understand that there's no right answer right now and build trust and be kind in our community. That hasn't always been the case, and Emily Wright's paper points that out. So I think it's extremely important to find those points of collaboration and realize that there's no one right answer today. We need to find common language and intersection and hypotheses that we can share and test together. We need to evaluate and alter the environment and stay focused on the health of these workers. And I believe the evidence is now clear that we have to be extending that to understand the health of families and communities, because this is not a problem that's limited to the workplace. We need to promote a discipline, a new discipline that embraces different areas of public health, environmental science, climate, and medicine if we're going to solve this terrible issue. Here's a list of our published papers. You'll have that when you see our PDF. And with that, gracias. And if there's time, I'll take some questions.
Thank you very much, Professor Lee Newman, and for this excellent talk. And this talk is open for questions. You can please, the only way is to use the chat, so please write over there. So when the people begin to write the questions, I just want to comment and give you the opportunity to talk more about the early detection of the problem, which is, we think, as a nephrologist, we think is really important, because it's demonstrate that the CKD, independent of the cause, of the reason, you can stop the progression of the disease. So you want to comment more in that field?
Yes, I think it's important to realize that by the time someone gets to the hands of the nephrologist, it may be too late. And so if we can move upstream to find earlier cases, I think that the way that needs to be done is going to be through better community screening, screening that is also done at the time that someone is entering the workforce, and screening not only for kidney function, but realizing that that coming into the work, we're seeing people with slightly elevated blood pressure, which we have some research that's indicating that the presence of even mild blood pressure elevation combined with the hard work makes for accelerated decline. So looking at other risk factors for kidney decline and for early kidney injury together at earlier stages in someone's work life is important.
And also the participation of the general physicians and the whole community, because when they refer to the nephrologist, the patients maybe it's so late, or maybe most of them are died. So it's really important to educate the community and also the primary care physicians. We have a question here from Professor Gerardo Arroyo. In interventions, did you not mention the participation of labor ministries and workforce? Do you think this is important for sustainability?
I think that in every country it's going to vary. In some countries you have stronger labor unions, which in my career I've always worked with the labor unions as well as with management, and then sometimes they both look at you and go like, "Can we work with you? Can we trust you?" And we go like, "Yes," because we are independent. If there are labor ministries, I think that it's important that they be involved at some level. Whether we're at a stage where the things that we have are ready to be institutionalized as policies across an entire nation, I still think is a question. But we need to be moving down that path ultimately because policy change will be the most enduring way of protecting these workers, will be policies. But I think we have to be confident in what the policies should say and how they are applied, because they can go in, as we all know, in more than one direction.
All right, we just have one last question, and then
Actually, sorry,
okay.
We don't have time.
All right.
There was another question, Lee, and perhaps you could respond to it just in the chat. It's from Christina Jacobson, and if you wouldn't mind doing that at some point, that would be great.
I'll be happy to. And I just want to thank everyone. At exactly the top of the hour, I will have to leave for another conference, but I want to thank you for giving us the time today. And please reach out to me or to Jamie.
Thank you, Lee. Okay, Dan.
Okay, so next is the Adelante group. I want to make sure that they are able to load their slides, that they have control of the, yes, there we go. Okay, well, without further ado, please start. Hello, we're maybe muted. David, Jason.
I had to stop sharing in order to unmute.
Gotcha, okay. A bug in Zoom.
So starting again.
Mm-hmm.
Thank you, CENCAM, for inviting us to this, and appreciated Lee doing the presentation he did, because some of the groundwork for our work has been laid by his discussion. What we call the Adelante Initiative is an effort to carry out interventions in Central America for the protection predominantly of sugarcane workers, or initially for sugarcane workers. Most recently, for the last 3.5 years, we've been working in Nicaragua, in Chinandega, northwest corner of Nicaragua, along the coast areas where it's hot, humid, and not a lot different from other coastal areas in Central America. The background for our work has been the belief that we need to act in the face of uncertainty as long as we have enough guiding information to move ahead. And Jason Glazer and LISA Foundation, now LISA work, identified the need for this several years ago, and began the research work that we started in El Salvador and now are carrying out in Nicaragua. There was and is evolving, as Lee has pointed out, sufficient evidence that heat stress contributes to chronic kidney disease of non-traditional origins or unknown origins that warrant attention to the protection of the workforce today. As a result of this, we designed an implementation research plan to explore the possibilities for effective implementation and ultimately the scaling up of that. Our research starts with assessing in Nicaragua at Ingenio San Antonio the existing prevention program they had in place, which did include rest periods, hydration, and some limited access to shade. After assessing that, we initiated some improvements in that based on our findings, and we assessed the improvements as well. And we continue to address the implementation support, which we find is critical and quite difficult, and continue to design improvements which include but go beyond the water, rest, and shade elements that have been discussed before. Ultimately, we intend to adapt the intervention to other geographies and other industries. I want to start by emphasizing something that in discussions of this we find frequently is not sufficiently. Heat stress, which is a risk for all human beings, arises from a combination of the environmental heat, which is associated particularly with work in the tropics and semi-tropical regions, but can be present anywhere in the world depending upon the climate. But it's not simply the environmental heat which is leading to heat stress, but it's the combination of that with any internal heat that's generated from the metabolism associated with muscular work. The greater the physical strain, the hotter the internal body temperature, the larger the problem, the greater the health risk. Also, well-documented increased accident risk and reduced productivity. So it's really critical to recognize these two elements. The external factors, air temperature, wind, speed, relative humidity, combined with heavy workload and piece rate work, which is common throughout Central America, the lack of natural shade in which to rest if rest is available, and very exposed land areas, and the complex clothing that's necessary to protect, for example, cane workers against the skin damage associated with working in cane fields, but that also results in some poorer discharge of internal heat. That combined with internal factors, which are the dehydration that Lee was speaking about earlier, associated with the need for rehydration, the metabolic load, which varies depending upon the nature of the work and the speed of the work, the health conditions that underlie not simply chronic kidney disease, but other diseases that are associated with the hazards of high intensity work and heat stress. Some differences among the sexes, although work with similar physical activity is unlikely to be very different. And then the superimposed impact of fever, either generated by the internal metabolic heat or by infectious disease or other illness. When we finished our first year of study, you can see in the slide on the left that this is the distribution, the blue line, of the WBGT levels over the course of the workday from 6 a.m. to 2 p.m. And the recommended periods of rest, 15 minutes, 30 minutes, 45 minutes, and then no work, that come from OSHA rest guidelines. It was thought originally that the heat would rise slowly enough and the problem would rise slowly enough that somewhere around 9 o'clock would be the first rest, and those were the rest periods that were already in place at Ingenio San Antonio. We discovered, though, in looking at the average core temperatures that we estimated for this population of a select population of burned cane cutters was rising much more rapidly, and by 7 a.m. after the first hour already getting into the danger zone of 38 degrees core temperature. We're looking at the average work intensity over work days for different groups of sugarcane workers. We noticed the sugarcane cutters were working at an percent maximum heart rate of 60. Same roughly for seed cutters, drip irrigators, and gravity irrigators, two other jobs in these work settings, were not operating at quite the high level of work intensity. To give you some idea what this means, the sugarcane cutters working at 60% for 5.5 hour work days, 6 days per week, compares with this roughly same level from military operations in the first day of 6. However, those operations don't continue every day for 6-month periods of time. Amateur marathon runners have average exercise intensity up around 80% of heart rate max, but that lasts 4.25 hours, and then they get days to rest from that. And then the ultra endurance race people who operate a little over 60 for 12 hours of 110 hours, they too get to, it's not a prolonged over months periods. If you look at how this maps the way we want to help think about this is to look at both intensity and frequency at the same time in the kinds of work we're studying. So the amateur marathon runners, the adventure race, the military operations, all high intensity, but not great frequency. The cane cutters, however, over here are operating both at a high intensity and a high frequency, and drip irrigators high frequency but lower intensity. When we convert the maximum, the work effort into predicted core temperature using a U.S. Army Research and Environmental Medicine well-validated way to convert work effort into core temperature, where you can see that both the cane cutters and the seed cutters are exceeding the maximum of 38 degrees centigrade internal body temperature, and all occupational health and safety standards recommend that that temperature not be exceeded. So it gives you some idea of where we really are worrying about managing this risk, combining external and internal heat. After the first year of observing the existing prevention program, we discovered that the burned cane cutters, 27% of the population we were looking at had some evidence of kidney injury, which we've called the incident kidney injury, over the course of the first harvest we studied. Seed cutters, 9%, and the irrigation and field support, almost none, although there was a little. Using a relative risk calculation, we determined seed cutters were 3.5 times more, had a higher risk, and burn cane cutters almost 12 times. This was something we felt is essential to act on to improve the intervention. So now, just to summarize my portion of this, the important thing is that we're operating in these research efforts in an increasing monoculture industrialization of agriculture and increasing work effort in such settings. Piece rate work is common, and piece rate work is a perverse incentive to work more actively than maybe physiologically reasonable or appropriate for the human body. We're pleased by the increase in research and surveillance that's ongoing, and we've been actively engaged in that. And of course, concerned very much about the warming climate that could make the situation a lot worse. Let me turn this over now to Jason Glazer to continue the presentation about our intervention assessment.
Hello, can everybody see my screen?
Yes.
Wonderful. Okay, so what do we do about it? What does this look like in practice? And thank you everybody for having me. I'm having a little bit of a problem switching slides. One moment. So what do we do about it? Well, we have to have scheduled breaks at prescribed hours. I think what we're finding increasingly is that shade tents that are transportable and close to the front where people are doing the work is incredibly important, because while people can be hydrated, as Lee's group and our group has found out, it seems to be hyperthermia is a risk that we really need to manage better in these interventions. And if actually you look back at a lot of the US Army and US ARM research, that holds up, that you can be hyperthermic and completely hydrated. And I think early on in CKD, NT, CKDu research, a lot of us conflated those things, and it was important to tease out. And it's really good that two groups have done that. The other one is maybe not something that jumps right to mind, but especially as more women are entering the workforce, especially in seed cutting and some of the other field jobs, you really have to offer appropriate sanitation in the fields. We can't very well ask women working with men to load up on water and hydration solutions and not provide a safe place to relieve themselves and take care of themselves. So if you look at those rest periods, which is kind of what I'm going to focus on a lot today, you know, you see Harvest 1, which is the kind of status quo, what they had running at the mill in Nicaragua at the time. And then what we introduced into Harvest 2, and you can see the percentage went up of how much time they had of break over the day, still well below OSHA standards. And I think that's something that gets to really what we have to figure out here. And I hope we can collaborate with Lee's group to figure that out, is we need something that's applicable to these tropical areas where if you followed OSHA standards, many days, nobody would be able to work at all. And so you have to figure out something that's appropriate, that protects health and allows people to be employed, and safely so. But you can see that we introduced a break a bit earlier in the day, more breaks, and it had some pretty favorable outcomes as far as kidney injury and people with eGFR below 60. You know, the shade tents, another thing that seems quite simple, but there's things that you want to make sure are occurring for those of you that are looking to do interventions in other industries that you may be working with. Some basics, you know, you got to make sure the material is breathable, that it can allow airflow and cooling, that the tent top is high enough, that it provides sufficient shade for the people under it, and that you don't overload them. I mean, one thing we see kind of too often still in implementation challenges is that maximum capacity for these tents of 15 workers often gets exceeded. And when you think about everybody being a little oven out there and all collected under a tent, that's not ideal. So it's really important that you have a tent that has two side walls to protect from the shade appropriately, it's breathable and mobile, easily mobile. Hydration's been discussed a lot. I think the two main things is make sure the water's clean, accessible, and also that all-important electrolyte solution. I think several studies now have shown the importance of that, both on the community level and the occupational level studies. But that should be close, and I think it's really important that it's accessible and that people also have insulated water so they enjoy drinking it. Sanitation in the field, I just touch on again. Obviously, in the time of COVID, you know, hand washing and alcohol provision is really important, and we're working on some of those issues as well now. We're also quite concerned about the interaction of any fever, any sickness, and heat stress. But, you know, well implemented, what does that mean? I mean, it means that tent really needs to be about 50 to 75 meters to the cutting front or the work front. So when you call a break, people can get back to those tents and get back to the shaded rest. That it's not a trial like it was early on when interventions were first being rolled out in the region, I would say about 10 years ago and maybe before. The old system was putting up a tent on the side of a bus. And so that bus is, you know, reflecting all that radiant heat, kind of acting like a big oven in the middle of a big open field, and then trapping the heat under a tent that sometimes people would have to walk back to over a full kilometer, you know, basically using up their break time, going over uneven ground and not really getting much of a rest or a break. So I think mobile tents that are close to the front allow for more easy access to water refills and more easy access to adequate rest. Also, stools are a good idea because they keep them off the heat of the ground. So, the impact of quality of implementation, I think we're seeing some interesting stuff here. This is from a paper we published, I think, back in March on the second year. If you look at the first year, there's a qualitative assessment that came in that the mill had 2 mechanized harvesters break down. And that meant that they then tried to get all of the workers, the burn cane cutters, hired to replace those mechanical harvesters. So there's about double the normal amount of hand cutters. And instead of buying or supplying more protection, they tried to spread out the material between the extra groups. So it was completely insufficient. And you saw a very high level of kidney injury. And then if you look in the second year, well, they really buckled down among burn cane cutters. I think they're quite concerned about what they saw the year before. And there really wasn't any difference in implementation between the cutting fronts, about 3 fronts represented in that 183 people. And the distribution of who had IKI was even throughout. And then the seed cutters you saw in the first year about 9%. And then the second year you see again that 9%. But they were really having issues adapting the intervention to the seed cutters uniformly. And I think that's in part because in the early days, the focus, before our time even, was really just on burn cane cutters. And I think our study, and I think now Lee's as well, is some of the first work to look at these other jobs that actually are indeed at risk. But what you see is a pretty, again, striking risk ratio. If you look at the best implemented group, it's only 1-2%. The intermediate group, kind of the status quo, is just kind of hovers right around the amount of people with IKI overall. And then the worst group, you see 21%. So I think implementation is key. And I think before we decide that water rest programs are not enough to block damage or prevent damage, I think we got to make sure we're keeping that core temperature down, we're keeping the hydration and the electrolyte consumption, and that it's not any different than, or not much different than adherence in any trial. Like if people aren't taking their hypertension medication, well, you're not going to see an improvement. And adherence is infamously a difficult thing at times for different populations. And I think implementation is really where we're starting to focus our work. And that obviously includes education, dissemination, and communication. So, aside from those observations and those results in the years before, we had the results where you see that core temperature from harvest 2, and you see it just really goes up fast. And incidentally, for some of you might find interesting that in US Army literature, people with heat stress illness, heat events, heat strokes, it generally happens in the first hour of exercises, regardless of the heat of the day. So there's something to that. Our bodies heat up really fast when forced or faced with extremely hard work. And I think we erroneously thought, many of us erroneously thought, we should give them those first couple hours in the day to cool off, or that are cool to produce and work hard. But I think that's a big mistake when you look at the data. So indeed, this last year, and we'll have results coming soon, although they were certainly impacted by COVID as far as collection being ideal. We introduced a break earlier in the day. And I think what I'm trying to impart here is what we're really trying to do is keep that core temperature below 38. For those of you interested in exactly why we think that, I think that's probably another presentation to go over some of the physiopathology findings we have, and we can share our paper on that afterwards. But a lot goes wrong when the body's at that temperature extended periods and repeatedly. So this is kind of an exercise in humility of like where we need to go and what we need to be aware of before we say that these interventions are only partially successful. I think they're partially successful as designed and as implemented. I'm not convinced I know we don't have sufficient implementation. We're not there yet. The mill's being very collaborative and cooperative, but there's still a way to go. Like any change, it takes time. But I'm not completely convinced where we need to be as far as design. And are we replacing intensity with duration? Do we need to make a longer workday with longer breaks? I think these are the things we need to model, we need to figure out, and we need to test. And some of our work this year is going to be doing some of that. But if you look at this workload, which can be commensurate with heat buildup, an internal heat load, is I look at these gaps, we look at these gaps, you know, and how fast the heat recovery is and how fast the workload recovery is. And there's a real question of, are these breaks long enough or sufficient? So is the design sufficient? Is implementation sufficient? I don't think we're there yet. Do I think we're there for the field jobs where we don't see disease of people from the same communities working in the same fields? Yeah, I think there's something to that. And I think we need to pay attention to that. But I think for these really high, heavy work jobs of the seed cutter and the burn cane cutter, before we can say water, rest, shade, and sanitation is insufficient, we have to make sure that what we're doing is sufficient. Happy to discuss that more later. So, you know, this is our big focus this year and the year that's coming is implementation. So ISA has a system. This is just a summary slide. I mean, there's many considerations going into, and Esteban Arias, if you have any questions, he can answer what went into his formula. It's really remarkable what he did and what will be coming out in our implementation paper. But you can see, even with ISA, the sugar mills observations, things are deficient way too frequently if you take it as a whole. And there's still a difference between when we did our site checks and our systematic checks, announced and unannounced, over the harvest. So even if they knew we were coming, there were things wrong. And when we did announce an arrival, things were still going wrong. And I think this is just part of training and support. But until I think that these things are up to the 75% green, I'm not comfortable with some of the conclusions I've heard that, you know, overall and through a lot of different quarters and commentary, that water, rest, and shade is not sufficient to stop injury. I think we don't know that yet. I think we have a big job ahead of us to improve implementation and assessment of it. You know, people ask
Jason, sorry to jump in, but just if you want to have a little time for questions, going to need to wrap up pretty soon.
We're there.
Okay,
yeah,
great.
Yeah, we're there, but no, good timing. Thanks, Dan. Yeah, so conservative estimate, everybody always asks, like, is this viable? You know, can this scale? It's something we think about a lot. There's actually 22% ROI for the mill, meaning for every dollar they invest, they got about 22 cents back. And that was on the low end of the assessment. That first publication is just in a report for the German Development Bank, but we'll have a publication coming out about it. On the outside of that estimate is more of a 30% ROI. Our question, of course, and I think there's a question everybody's thinking about who's working in this space, is how do we adapt these things to kind of small farmers and outgrowers and groups that don't have the resources of a giant sugar mill? Our next steps, well, I'd like to announce today that we have a really lovely collaboration forming with PAHO focused on occupational health and CKD and mitigations. And we're also working with them on some COVID mitigations in the industry. So I just want to thank Julieta, who really made that happen. I think that's a great thing to help get more onboarding from health ministries and labor ministries in the Americas. But what we really want to do is maximize these intervention improvements we've designed. We got to really scale to the entire supply chain. We're working on a project like that starting next harvest, not this harvest, with the Inter-American Development Bank, it looks like, and potentially all the mills in Nicaragua to get the entire supply chain up, not just the mill owned land, and also to address some child labor, early exposure issues that have emerged in those outgrowers, in those supply chain farms. One thing we really are focused on is improving law and certification standards. So we are deeply involved in improving the certification for Fair Trade USA, or for Fair Trade USA, Fair Trade International, and Bonsucro. And Inika and Alana are both really involved in that. And then I think another big thing is, like, what does this actually mean for people, including dropouts who are able to locate, because we got a nice ground game in Nicaragua after 4 years. Like, what is their actual kidney health after 4 years? But just thank you. Thanks for everybody showing up and hearing us out. I think it's really important, as Lee said, that our groups work together and share data and combine efforts. And then we got to start thinking about other at-risk groups and indeed what other risks there are out there. We wanted to stay focused on the risk of heat stress. And we are looking at other exposures. You might notice on the worker to the left, you can see an air collector to look at respirable dust and what's in that dust. So much more to do. Thank you so much.
Great. Thank you, Jason and David. Really interesting. Two really good and educational presentations. I'd like to allow for a little bit of time for questions. First, we have a question from Marvin Gonzalez. How did you deal with loss of follow-up within the harvest?
Well, Marvin, we learned from the best. So Marvin's amazing at it. I'm just going to embarrass him a little bit. I also work with him on the community cohort study and helped get that going in Nicaragua with him and the group at UCL and London School. And it's pretty remarkable when you look at a community study 3 years in. I think he's got over 90%. So it's just tenacity. You have to have good data on where people live. You got to have trusted team members on the ground, which we do. I think you saw the email I sent about William Martinez, who used to be a cane cutter himself. But having someone like that who's got the educational chops, but also the local know-how allows us to, get that loss to follow-up, the dropouts. And then the goal is at the end of this year is to look at everybody who's been around in those 4 years and see where their kidney function is, looking back. So that should be really, really interesting. But it's a really important question, because if you don't do your loss to follow-up and your dropout, what we've already seen is you get a pretty significant underestimation of kidney injury. Actually, as much as 6% or more.
I'll ask a question. Well, I'll wait to see if anybody else would like to jump in. I was intrigued by the seed cutter and burn cane cutter data. As you said, Jason, it's always been seen as that it's really the cane cutters who are experiencing, and if you just look at the heat exposure, it's just as high in the seed cutters. Do you think that a lot of I think the prevalence studies have generally thought that maybe the cane cutters had these higher rates. After doing all this work, do you have an assessment about whether they're kind of at similar kinds of risk, given that they're at similar predicted core temperatures?
Yeah, if you always have to go through these. It's a great question, first of all, but I think really specific and really needed. It's funny, actually, I think the seed cutters in the most recent data, they actually have a slightly higher core temperature now and a longer period of the day now that they're exposed because their workday is longer, and a higher level of the day at that core temperature and workload. So the percentage of heavy work. So we have a lot more coming on all that. But what's interesting is because burn cane cutters were such the obsession for so long, and Dan, you and I may have had something to do with that in our earlier work, and it wasn't for nothing. That's what the signals were. So that's what you pursue, and it was early days. But it is remarkable now that you see that the burn cane cutter is actually a little bit lower as far as poor outcomes than the seed cutters, but they indeed also have a little bit lower core temp and other metrics that we're concerned about. So yeah, does that answer your question? I find it really interesting because it really seems to correlate really well. It's obviously early, it's obviously just 1 year, but it's hard to ignore those risk ratios, and it's hard to ignore those associations and not keep wanting to dig.
Right.
Dan, I'll just add that our assessment, we're dealing with a moving target also that has to be accounted for.
Meaning, sorry.
That the difference may not be as close. The magnitude of the workload may not be as close as we're indicating now.
Gotcha.
Historically.
Yeah.
Oh, yeah. True.
And I always worry about that question of when are you crossing a threshold? So many things in the body and its responses physiologically. Is there a threshold? Is it subacute? Is it acute? Or is it a combination thereof? Is it both?
Right.
I think there's just a lot to unpack still.
Right. So let me just say, I think I want to perhaps call it an official end to the webinar. Just because people, I want to be respectful of people's time, and we're into the 1 o'clock hour in Central America, 3 o'clock hour where I am. But if people want to, if anyone wants, there is another question that was on, and if Dr. Arroyo can stay on, that would be fine to answer it. I also want to thank both, I assume Leah's gone, but I want to thank both groups for really excellent and presentations. I personally learned a lot by listening to you, and I think that looking at both of the different types of studies, I think that there's a lot to be shared. And also just to reinforce that both groups will be posting these slides, which I think will be a very good resource for both of us. But for those of you who have to leave, thank you for joining us. And we hope that you will join us on a future webinar. Thank you very much.
Thank you, Dan.
So meanwhile, we had a question from Dr. Arroyo, which I need to scroll down to get. There we go. Can you comment on interventions in children from ill workers in the household environment? So yeah. Do you have any have you gotten any information or any on that?
I kind of have David, do you want to take this? Or you want me to take it?
No, you take it.
So, La Isla started out as a community organization before we really focused on these interventions in the occupational setting. And we still have that going on, but it's led by a local team on the ground, and we support them in that. So 3 points, one, there is definitely a lot of child labor still going on, and it's sometimes intermittent, and sometimes it gets cracked down on and it rears its head. So I think we've really got to think about early exposures in those fields, be it heat stress or otherwise. And we are working on that. Now in the contracts the mills have with their outgrowers and their suppliers, that they don't actually own the land, it's not happening in the workforce we study because they're all directly employed, but it's the contracted work. Now the contracted say no child labor, decent practices, but there's a big gap and it needs addressed. So that's one, we are gonna do it. I think it needs eliminated. But two, support for families. I think the scale of this thing is so big, no one small organization can do it. What we have done is provided potable water to the community that we take our name from. And it's a deep well tested water system in several communities, pipes right into people's homes. So that's something, because you can't very well tell people to drink more water if they're worried about drinking it. And if there's something in the water, that just seemed a very simple precautionary thing to do. And then financially, we've done a community economic impact study, and it's on our site. I would take a look at it if you have time. But we're doing something kind of interesting in Nicaragua. People that get this disease, if they work a certain number of weeks in at-risk, what are considered at-risk groups, actually get Social Security in Nicaragua, which is quite progressive. However, many people, as Marvin's study has showed, as our study has shown now, get sick in 2 or 3 years. Although I think it's longer than that. I think a lot of them are working as kids before they enter the formal workforce. So they don't qualify. And it turns out you can pay the difference in Social Security and provide support for families and sick workers that way, at least some amelioration to the poverty they're facing when they're out of work. And all you have to do is pay the difference that they miss in Social Security. And this is $800 per person, which would then lead to thousands of dollars over time in treatment and support using the existing system.
Interesting.
So, but I think that this thing needs a lot more support from the development banks and other aid agencies on the community level. There's no one small org that can do it. It needs and deserves so much more direct aid. I hope that helps.
Sure. Continuing on. Hello, we still there or are we lost?
We're still here.
Okay.
I'm here. Yeah, no, but that was it for child intervention.
Yeah. No, I just thought I heard everything go blank, but not. So just continuing on, we have a comment from Ineke that the burned cane cutters have now less heat stress than historically. A very good point, and something that's really important to consider when we're trying to think about, when we're doing studies today, we're not doing it on the same, a group of people are having the same exposures as when, this first really exploded on the scene. It has been going on for some time, but when it was perhaps at its peak, there were different conditions. Marvin asked whether it would be feasible to implement an intervention study at the community level.
I mean, is it feasible? I guess it depends. I think part of it would have to be education. I mean, certainly something that we want to do is create a matrix for heat, stress, and workload, and then provide recommendations based on that, and for the region, for each region, based on Tmax, temperatures, et cetera. Because clearly these OSHA guidelines are just almost useless in these populations.
Yep.
So we have to come up with something new, and then we have to validate it, and that, that's an effort, right? So first, I kind of want to know what jobs in most of these affected communities are at risk, and of course other risks. But if we're just talking about heat stress and workload, I think we got to build that matrix. And then yes, could we do education and build systems and communicate to communities and workers what they can do to protect themselves if they're not getting protected by their employer? Yeah, but I do think this really requires a structuralist approach with employers involved, with health ministries and labor ministries involved. Because I think, there's going to be a lot of barriers to people being able to just say, oh yeah, I can take care of myself.
Very good. Well, we do have people saying, including your colleague, David Wegman, that they have to sign off. I myself have to get going, but I just want to, perhaps we should end it at this point, but just want to reiterate that I think this was really an excellent webinar. Thanks. I think that the original suggestion came from La Isla, and so I'm glad that you had raised that suggestion and that we were able to follow up on it. And we look forward to more discussion on all these important issues.
Thank you, everybody. It was a pleasure.